Welcome, community. Chronic Pain Australia acknowledges the traditional custodians of the lands on which we live and of the many different nations across Australia. We pay our respects to elders past, present, and emerging as the holders of the memories, traditions, culture, and spiritual well-being of the Aboriginal and Torres Strait Islander peoples. We acknowledge any sorry business that may be affecting the communities as a whole. I'm so pleased to be chairing this session, which I hope will provide many of you with clarity on a topic, chronic pain and surgery. There is frequent media that shines a light on significant issues in the treatment of chronic pain, but sometimes this leaves us with unanswered questions and also concerns for those who may have been recommended surgical intervention and now questioning that recommendation from their health professionals. We have carefully curated an expert team with the aim of providing cohesive, practical session that is free of bias. We hope this session will serve as a trusted and reliable source for you. So we are joined today by a wonderful panel, and I'll start with Dr. Dilip Kapoor. He is a pain specialist, physician, and Dean of the Faculty of Pain Medicine, who has extensive experience in pain medicine and a keen focus on rural communities and First Nations health. Welcome, Dilip. Professor Toby Newton-John is a professor of clinical psychology at the University of Technology, Sydney, with an interest in chronic pain management. Fiona Hodson is a pain management clinical nurse consultant who has worked in public tertiary pain clinics for over 26 years, with expertise in all aspects of pain service delivery. And Dr. Tim Austin is a specialist pain physiotherapist, chair of the Australian Physiotherapy Association Pain National Group, and lecturer in the Masters of Pain degree program at the University of Sydney. So welcome all to our panelists, and we've collected this multidisciplinary team to sort of really unpack the issues of chronic pain and surgery. And thanks to this panelist discussion, I think we're going to get some really amazing practical tips. So we do hear this term used quite frequently in media and from health professionals and some consumers as well around high value care in chronic pain management and low value care. And sometimes it's a bit confusing to understand what is high value care and what is constituted as low value care, particularly when we're looking at chronic pain. So Fiona, could you provide some clarity for us on what is considered high value care in chronic pain management?
Yeah, thanks, Nick. We do hear this term a lot in the media, and it really, high value care is for which we're looking at evidence that will suggest that the benefits to an individual, there is a much higher probability that the benefits will exceed any sort of harm. But in more simple terms, I think what high value care in pain management is when it's patient-centred, it aligns with the individual's priorities and realities, and it also allows them to foster their own self-management aspects, and they can actually then, have successes rather than, failures if they're doing other, management strategies and that aren't actually appropriate for them. So that's what I think is really high value care. But as I said, I would really like to emphasise that patient-centred approach to it.
And Fiona, do you have some examples of what you would say in practical terms would be high value care for someone with chronic pain?
Yeah. It's quite simple and it doesn't cost a lot of money, but there is a lot of evidence out there that shows that if people are more educated around pain management and what we refer to as the neuroscience around it as to why they have chronic pain and why it persists and it's ongoing and what can actually help and facilitate people to, manage their pain is one example. Other non-pharmacological approaches, which is around, people doing some relaxation exercises, reducing their stress, connecting with them, with family and community and things like that. But also a lot of the allied health, like physiotherapists and the psychological interventions that are used in pain management is what I would see as really high value care.
That's all. And Dr. Dilip Kapoor, what would you, in your experience, constitute as low value care?
Yes, thanks, Nick. In many ways, there's quite a simple definition to this, and it goes back to economic terms when we're talking about value that's placed on things. We need to look at what the outcome of a treatment is and what the cost of that treatment is. There's also one other important thing, though, that joins in with this, and that's the risk of the treatment, because the risk must always be added on to where the outcome goes. Now, there are big mistakes that are often made here in terms of what might be care that's high value. Care that's high value is not care that's expensive, because there's some forms of care that can be very expensive that result in poor outcomes, and obviously the value for that is very low. Equally, there are relatively inexpensive interventions, and Fiona has very accurately portrayed some of these just now, that have the opposite. They're relatively inexpensive, but the outcomes are favourable. The risks are significant, though, and it's important that if we're looking at things from a broad perspective, we need to understand some of the risks that go with forms of care that actually make them low value. A good example might be the use of potent opioid medications in some pain states. For many people, they won't be helpful, but they will lead on to secondary problems that are actually incredibly expensive to deal with. So there's simple and obvious ones, such as things like intractable constipation, sedation, negative impacts on mood. These are all important outcomes. And if that's in a setting where pain has not been effectively managed, as is often the case with opioids, then the actual value of the care obviously becomes quite low. We'll be talking about some other issues, though, a little bit further down the line. But it's as well as negative outcomes from the simple biomedical perspective, we need to think of the negative outcomes from other perspectives, and in particular the psychological and social perspectives. A good example of care that turns out to be very low value is when people are given erroneous diagnoses for conditions. And a real problem with diagnoses is that they often become very sticky amongst health providers, and sometimes also patients as well, where the diagnoses aren't explained well. And there are many examples of this, but unhelpful diagnoses see people trapped in a bit of a loop with further investigations, with possibly even further unhelpful diagnoses based on the additional investigations, and that helps nobody. It does make patients more anxious about where they're going in terms of their health, and it impedes recovery. And finally, a little recognised risk, but a really important one, is the social effects of care that doesn't generate outcomes, but does actually involve a lot of time and resources from the patients, because these are time and resources that could be spent developing networks amongst friends, supporting networks within the family. And finally, there's a simple one. When people aren't well advised about how to spend their health dollars, they spend their health dollars on things that don't work, and it makes them poor as a result. So all of these would fit into the broad framework of what I would term as low-value healthcare.
Thank you for that, Dilip. And it really shows, I guess, where we have moved over historically in chronic pain management from a very biomedical approach, and we're trying to move and shift the health profession and people living with chronic pain to a more holistic approach, the biomedical, psycho and social approach. So I think that captures it really well. And now I'm going to move over to Tim and break down a treatment assessment of scans and MRIs, where they're used quite often to assess people with chronic pain. But I guess in most cases, they would be considered as low value care for chronic pain management, particularly in conditions like chronic neck or lower back pain. So, Tim, can you explain the relationship between scans, MRIs, and someone's pain experience?
Yeah, thanks, Nick. Look, the challenge with scans is a scan of any varieties is a picture of the inside of your body. And it's quite fascinating. We all love to see them, and we're all a bit amazed by them. But really built up over, you could say actually hundreds of years, we've developed this idea that if we look at the structure of the body, we can tell what's right or what's wrong with it. And so it's built up this idea that if we see something on our scan and it's not exactly what our textbook tells us a scan or the inside of our body should look like, then that's a problem. And that's really the fundamental nature of what that biomedical model is. Whereas what we actually know is a couple of features. Structure has a very limited connection to what pain we experience. And simple analogies of spraining your ankle, but while you're running across the road and not experiencing pain, tells us that we can actually damage ourselves and not experience pain. But we can also have scans that show us various things. And if we go to the population out there who doesn't have pain and we scan them, they have a lot of the changes, disc bulges and those sorts of things occur very frequently in people who have no pain. What's very important to say to people is it doesn't mean that people's scans are irrelevant if they've had them. It just means that as clinicians, we need to look very carefully at the pain somebody has, put it together with a scan that they may have, and to see what links that we can determine that give us some sense of connectedness between structure and pain. And there are some situations where there is a strong suspicion of nerve involvement in particular. And so these are what we call red flags. And any clinician who does an assessment on you from a biological perspective, a physiotherapist, a doctor, will explore you for those concerning signs. And when you have those concerning signs, then that's an indication for a scan. But often when you have non-specific, as it's called, neck pain by itself and back pain by itself, without any referral of pain down the arm or leg, then most of those situations a scan is not required. And people don't realise this. And there's an assumption that the scan will show their problem. There are also other problems when you do have scans. As we all get older, the inside of our bodies looks different, even when it's completely pain-free. And that can be very hard to explain to patients because our scans involve terminology that in itself is a bit alarmist. When we hear something like a disc bulge or we see arthritis in joints or something like that, that all sounds bad. But, sometimes the example is given that as we get older, we all have a few more wrinkles. But those wrinkles themselves aren't actually a structural problem. We may not like them, but they're not actually a structural problem. And that's the same as many of the changes that we see on our scans. And I'll pass here to Toby because, when people see reports on scans, they can be quite concerned, can't they, Toby?
Tim, they absolutely can. And geez, that was a really lovely explanation of what is a really complex area. And I think you've nailed so many of those important elements there. So yes, on the back of what you're saying, I think the idea that most of us walk around with ideas about our bodies and how our bodies work, and generally speaking, those ideas are pretty mechanical in that we think of our bodies working normally or not working normally. And scans can reinforce that idea that they're not working normally. But as you said, Tim, when you combine it with words like trapped nerve or bulging disc or desiccated disc or wear and tear or arthritic changes, for a lot of people, those terms convey danger. They convey inappropriate levels of structural abnormality, which the assumption is they will require some sort of further investigation or correction in some way. And it's that kind of inadvertent conveying of worrisome knowledge, which as clinicians we get and can become a bit blasé about this sort of stuff. They're terms that we knock around with each other all the time and we know what they mean. But I think anyone who's worked in the pain field for any length of time will be familiar if the patient comes in absolutely aghast that they've been told they've got wear and tear in their spine. It's a really distressing idea. If your back is hurting and somebody tells you you're worn out, your back is worn out, you'll put those two things together and change behavior, and not in a healthy way, in general terms. So I think it's such a great explanation, Tim, of what the problem is, and this is just an extra note of caution for clinicians to be very careful about language at all times, but particularly with the use of labels and terms, because our understanding isn't necessarily the understanding that the folks we're treating, we're working with has. But equally, for people who have been given these labels to be able to take a little deep breath here and think, okay, well, perhaps it's not quite the assumption that I had. It's not like, a car that you put on a hoist and you see a hole in the exhaust and we'll just fix the exhaust and you're back to normal. That's not what we're talking about in a very mechanical kind of way here. And unfortunately, the way language has evolved with describing some of these things, it can be fear provoking. The idea of things being trapped or stuck or bulging or it's a very unsettling way of thinking about what's happening in your body. When in fact, as Tim was saying, in aside from those red flag situations, it's part of the normal process of what happens to bodies on the inside.
And Toby, part of that, I guess, is also that fear avoidance. So it's not just about the belief that my back is broken, or I've had, people that I've been working with that were really fearful that they'd be disabled and in a wheelchair, and that felt like that was part of their reality because of those words. And then it comes out in behaviors as well. So they avoid activity, which then increases pain and distress. And
absolutely. And I think that's the sort of I was alluding to in that behavior change thing. I'm sure clinicians don't anticipate that's what's going to happen as a result of what they feel. They're just explaining the results. But it's a kind of logic that if you've been told, or your understanding is that your spine's wearing out, then the logical thing to do is to preserve it as long as you possibly can. It would make no sense to then go and use it. You can just like a battery that you're going to run out before you. So the kind of logical thing to do, if that is your understanding, is to not move and preserve it as long as you can. But very much, Nick, as you said, the consequence of not moving is degeneration and loss of contact with a sort of a valued world. So it's an awful and insidious sort of vicious cycle that happens way more often than it should. And of course, then as people get less and less active and less engaged, they do hurt more, which seems to reinforce the idea that there is something terribly wrong with them because they weren't this bad last year. And so it sort of continues. So, the idea that from what seems fairly innocuous, just explain to somebody that you scanned, showed these wear and tear changes, or you've got this thing, can start a cascade of understandings and behavior changes, which lead to that person really suffering way more ultimately than they really should.
I'll give people an excellent example, Nick, from one of my patients helped me with this just yesterday. We were talking about this, and he had this realization, and we've all had this. He said, it's just like a hinge on a gate that you see, and sometimes it looks a bit rusted and it doesn't move very well. But then you squirt the WD-40 into it, and you actually start to move it a little bit, and it starts to move. And this is, we've used that example for years. But then I had that realization that when you go back and your hinge works like new, doesn't it? We all know that we get a bit of lubricant and it starts to move. But if you go back later and have a look at your hinge, what does it look like? It still looks just a little bit rusty, doesn't it?
It's not.
But it actually moves really well. And it actually reminded me that, of course, as we go through life, things look differently, but they don't have to function differently. And so helping people to see that is very important.
It's a great analogy. I like the rusty hinge. Dr. Dillip, I wanted to also move to you because it's quite often that I hear, I don't know why I wasn't given a scan or an MRI for my pain. Is there times as a pain physician that you think that that is a good approach in the assessment and treatment of someone with chronic pain?
Yes, absolutely. But I'd like to make a couple of points here because they're very important to understand. When I was a medical student, I remember when we were first taught diagnostic skills, then one of the key things that we were instructed in was that you have a series of processes for making diagnoses. Number one, you start with a history, and the history will give you 70% of the information that you need. The physical examination that you then perform will give you another 25%, and the investigations will give you 5%. Now, over the years, I've actually had to revise my apportionment of where you get the accuracy from. And I think in chronic pain, the history will give you at least 80%, possibly more than that. The next thing, though, that's incredibly important is competent physical examination. And it's a rather distressing fact that clinical examination skills and that translation of the use of clinical examination skills into assessing patients appears to have declined over the years. And that's very unfortunate. It's unfortunate for two reasons. Firstly, most patients know that as a doctor, you're supposed to put a hand on them somewhere. And when you're not doing that, immediately there's a potential real loss of trust. And that loss of trust, frankly, is deserved because as a doctor, you, particularly seeing a patient for the first time, you must examine them. Now, we end up with our 80% from the history, maybe, is it 15% from examination? Possibly a little bit more than that. But it still means that overall, what we'll get from investigations is quite small. But sometimes the investigations will be the key to something. And a good example will be the patient who presents, as Tim has said, with a potential red flag complaint. So a patient will attend, they'll say, I've had severe back pain. I can't walk well because the pain spreads all the way down my right leg, and the toes in my leg feel numb. Now, it will be quite easy simply to send that person off for an MRI scan, but the better thing to do and the most accurate thing to do is to perform the standard assessment, examine the patient, and what you then do is you use the investigation to which you refer the patient to confirm what your diagnosis is. Because a really important fact about the eventual confirmation is the examination can tell you that the patient perhaps has a nerve root compression. The examination should also be able to tell you exactly where that nerve root compression is. But in rare circumstances, the nerve root compression will be due to a slightly different cause to what you suspected initially. So this means you actually have a logical pathway that guides you through the whole clinical assessment process, so that when the patient comes back to you, as Tim has accurately outlined, the scan will inevitably say there'll be a couple of annular tears at a couple of levels, but you're not really interested in that. You'll point the patient to what you see at the level where there is a large disc prolapse compressing a nerve root. So that's the really important fact that we have there. We've had a strong suspicion about what the diagnosis should be, and we've had that confirmed by an appropriate investigation. The problem with doing investigations for things that become a lot less specific, it brings us back to the point that Tim made. There may be so much on there which will have a name attached to it. Very little of it will be relevant. Now, we focused here on things around the spine, but it's equally relevant in other areas. If we look at scans of the shoulders, for example, a proper investigation of a painful shoulder, together with a history, should give you a really clear idea about what might be wrong with the shoulder. But if you put the cart before the horse and do the scan of the shoulder before you've actually undertaken a proper examination, you'll always find things wrong with the shoulder of an average 50-year-old. And again, they actually sound quite alarming. Conversely, though, if you've actually taken a careful history of a person who has maybe a middle-aged or elderly lady who has fallen onto her outstretched hand, she's actually developed severe pain around the shoulder. She finds that she can't lift her shoulder away from, can't lift her arm away from her side. You examine the patient, you heard the history, you've got a very strong suspicion that this lady has probably ruptured her rotator cuff, probably the supraspinatus component of it. And on the basis of that, it's perfectly reasonable to do an ultrasound examination so that if you need to refer for further treatment, we've actually got this logical sequence that's confirmed what we thought that will guide appropriate treatment, and we can make sure that we stick with high-value treatment, as we've talked about previously.
Wonderful. So in practical terms for a consumer, really, they should be questioning their own health professional as well, that they are assessing appropriately, doing a physical examination, and then deciding on whether or not they should scan or do an MRI. Is that
absolutely?
Yep.
Absolutely. And to come back to a point, interestingly, when I've had both medical students and physiotherapy students with me, they've asked how I can do a neurological exam so quickly. Well, the simple answer to that is I've been doing it for 40 years, and you run through a very quick system. But in any area of competence, people should be able to find themselves consulting a practitioner who can do a competent screening examination in a relatively short period of time. And the point you've made there, Nick, is an interesting one, because when I've been teaching on group pain management programs, we've had a really popular session with patients attending the programs about tests. And one of the first questions that I'll put to the group is, why do doctors do tests? And the number one answer that always comes out is to find out what's wrong. And unfortunately, I think that's a failure of medicine to help people understand why we do investigations, because that's not why we do investigations. We do investigations essentially for two reasons. Firstly, to confirm clinical examination findings that we've made, and secondly, to guide treatment. Because if we make an examination finding and we're actually certain about the diagnosis, but it is not going to change the treatment at all, we have to ask the question, why would we do the investigation after that?
Wonderful. Tim, I see you profusely nodding your head to all of that, and I was just wondering if you had anything to add. Just unmute, Tim.
Yes, I affirm that. Just one other comment we'd make. When we start to discuss these things, we always want, as Fiona said right at the very beginning, a good clinician will affirm for the patient that they've been heard and try desperately to understand and acknowledge their expressions of pain. Because sometimes when we talk like this, and we all agree about this, but that can sometimes come across as if we're not believing the patient or something like that. This is the real challenge that we want to say to people. If you have pain, we hear your pain, but we want to get beside you and work with you to help you to understand this better, to try and understand where you're coming from. And we know that sometimes we might be coming in with some different ideas that no one's ever explained to a patient in the past, and that could be challenging. And so for all the patients who are listening to this, make sure that you express yourself and that your clinician should be validating your experience, never telling you that it should or shouldn't be like that. If it's like that, then it is that. And then let's try and work together to try and understand why it's like that and how we can best help you to move forward.
Wonderful. And validation is such a key part of chronic pain management and should be just an essential component of any experience for someone with chronic pain. So lower back pain is the leading cause of disability, not only in Australia, but also globally. And it's been in the media quite a bit around lower back pain and surgical interventions and investigations. And it's broadly sort of categorized into these two components, Tim, which you were alluded to before, which is specific and non-specific lower back pain. They're quite confusing terms for the average person. So what do the terms mean? And how do you know which one you sit in as someone with back pain?
This may not sound very helpful, but it's also confusing for us. It's not always clear. Very, very simply, to define it is very simply, specific low back pain is when there is supposedly an undeniable source of pain, an undeniable source of a structure that is causing pain. And non-specific relates to the fact that there are, particularly in our spine, there are many structures that have nerve supply. And technically, any structure that has nerve supply can be a source of pain. But in the back, because there are so many structures, you can't, and you probably don't need to differentiate if it's one structure or the other. Now, this actually still remains quite contentious. And this is where patients can be left confused, because one particular clinician will think it's specific low back pain, and they may refer to a scan. They may refer, as Dilip says, to something in an examination finding, and that can be very challenging. To this point, I don't believe that we've come up with a perfectly foolproof system of determining in low back pain one specific structure over another. We do have different tests that we perform that raise our suspicion of certain structures over the others. But I'm very aware that clinicians who listen to this may well have a different opinion. But this is the challenge. The concept is simple. Specific is a known structural cause, and non-specific is when we cannot identify that. And arguably, we don't need to identify it because we're going to do a functional process of recovery, and that's very important for people to understand. Sometimes we think of back pain as if you fall over and you break your arm and you get very specific pain in the fracture, and your pain and your damage make perfect sense, and then we treat that and the pain goes away. And the incorrect assumption is that we'll do the same with our spine, that we'll do that scan and we'll find that particular source of pain, and then we'll somehow treat that source of pain and make pain go away. We've known for 40 years that pain is what we call a biopsychosocial experience. We experience pain, and there are multiple contributors. And in chronic pain, if you don't explore all of those contributors, then you are likely not to consistently assist patients, because you're going to miss things. Back to what Dilip said, you've got to do a comprehensive history taking, which gives you the opportunity to find out the vast majority of things.
Wonderful.
Just follow. Sorry, Nick, just quickly, because the point I think it's really important in everything we've been talking about in terms of labels and non-specific and so on is the fundamental human need for explanation. We want to understand what's happening to us. And so from the patient, from the consumer side, you're looking for a reason that you're hurting. And that's just a basic human way of making sense of the world. So we're feeding that into a system which has ambiguities in it and has difference of opinion in it, and it's not a great mix sometimes, because people don't want to go away with they don't know what's wrong with me. That's a very unsettling sort of position to be in. So, again, it's the onus is on us as clinicians to use language and use appropriate terminology and to validate experience, but make sure that we're doing it in a way that's really helpful for that person and not in any way coming across as being dismissive or not understanding or not supportive, but equally not alarmist either, because giving somebody a label which is going to cause fear and apprehension, that's not an explanation. That's an undoing of function. So it's a balance of a lot of things, isn't it?
Toby, you bring up a really good point, because on average, I think it's 70% in the National Pain Survey for 2024 took 3 years to get a diagnosis, and then 10% of those people don't have a diagnosis currently for their chronic pain condition, which can lead people being really distressed that they can't call this a particular name, and the thoughts that it's all in my head, etc. How do you, as a clinical psychologist, sort of help people work through that? Because the management of chronic pain will still be that MDT care.
Yeah. And they're awful figures, aren't they? It's sort of terrible to think that in 2024 we still haven't made as much progress as we should have made in educating the community, and I'm talking about the healthcare provider community as well as the consumer community about these sort of things. If the default position is, if they don't know what's wrong with me, there's one of two things. It must be in my head, therefore it's not real, therefore there's something inadequate about me, or it's really serious. And I need to keep finding somebody who can keep investigating to find this really sinister thing that's wrong with me. Neither of those two things are helpful for people. So I think that the starting point is as Fiona referred to, this idea of pain neuroscience, and that's a very broad term. But I think what we have done, at least as a research community, is understood the complexity of persistent pain, and as Tim alluded to, the multiple aspects of the things that influence people's pain experience. And so the starting point really is helping people understand that we used to think it was fairly simple. The more the damage, the more the pain. No damage, no pain. That sort of idea. And we've shown time and time again, from basic science all the way through to epidemiology, that's not how persistent pain operates. It's not how acute pain operates either, frankly. And so helping people almost reset their understanding of what's happening in their bodies in relation to this particular problem is a place to begin, because those concerns that somehow it's not real, somehow it's some frailty of mine, which is why I have the pain, which is such an invalidating and frankly unscientific way of thinking about things, versus there's something really awful and I need to keep seeing another specialist to find out, well, that is also just as disabling in its own way. So it's an opportunity to kind of reset thinking, and science has been moving forward and our understanding should move with it. And pain's one of those areas that my sense is this sort of our general understanding is still very sort of 18th century, and yet the science is changing and has changed so much, and we need to do a better job to disseminate that understanding so that people think of chronic pain like a chronic disease of diabetes or anything else, that it's something that you can manage. And I have a colleague here who's diabetic, and no one knows she's diabetic because she manages it, she goes on with it. It doesn't. It's one of those things that it doesn't have to ruin your life if you've got good advice and good care and good self-management strategies. So I feel like there's still a big gap between what we know and what we're sharing with people who are living with this.
Yeah, that education piece is such a major component of chronic pain management.
Nick, can I just weigh in on that? Because I want people to understand what a diagnosis is too, which we understand now. Only in the last 5 years have we technically had a diagnosis where pain itself is the diagnosis. Toby talked about diabetes. We understand that to be a disease. And the actual way that diseases are classified, this is really tedious and boring, classifying diseases, except prior to 2019, officially, pain could only be secondary to something going wrong in the body. It had to be secondary to something, whereas now we recognise pain as what's called a disease in its own right. And I don't necessarily like the term disease because, as Toby will say, it's very alarmist. But what happens, we know, is that's why I don't necessarily like specific and non-specific. What I like is a definitive structural source or adaptations of the nervous system that prolong the experience of pain. And that can be a diagnosis. And often when you can say to a patient, these constellation of things are going on that tell me that your nervous system has adapted, that's not in your head, that's real. But if we keep chasing structure, when the problem is in other adaptations of the nervous system, we're not going to get an outcome. So your diagnosis is a pain diagnosis, and we can stop that fruitless search for another diagnosis and get off that merry-go-round.
Wonderful words, Tim. Fiona, I'm going to throw to you around multidisciplinary team-based care, and what is that? What does it look like in practical terms? And then we can talk about the access issues.
Thanks, Nick. Yeah, as Nick mentioned before, I've worked in a public hospital in what we refer to as a tertiary multidisciplinary pain centre, and what that term multidisciplinary refers to is lots of different disciplines in in healthcare. So a core team in a pain unit in a tertiary centre, I'll explain that one first, is generally there's a medical officer, there's physiotherapists, nursing staff, could be an OT, there's a psychologist, psychiatrist, so could even be a social worker, pharmacist, dietitian. That would be the ultimate multidisciplinary team. But what that refers to is that everyone is working for that patient in a holistic way. So even though they have their discipline-specific ways, like the medical officer will generally do the assessment and looking at some diagnosis stuff, other team members will come on in and look at other aspects of that person and and look at ways that they can help manage and understand their pain. There can be one person that can work in what we refer to as an interdisciplinary way. So I, myself as a nurse, work in a very interdisciplinary way. So I might be talking to one of our patients and talking to them about, dietary issues and inflammatory responses with some of the foods they might be eating. Or, someone might be very, stressed. And so we'll look at some strategies where we can sort of help them to manage their stress well. So we all work as a team to support that person with their goals, what they can actually achieve, because part of what we do is never going to work if it's completely unachievable for the patient involved. So like if a patient is physically unable to sort of walk 10 kilometres, then, we're not going to give them a plan that's going to get them to walk 10 kilometres. So we've got to work on pacing them and looking at some goals. So these teams also can exist in the community. And one of the key issues that you bring up, Nick, around access in the community, as I said, in the pain management centres, we see probably less than 10% of people with chronic pain, and the majority of people can be managed in the community with good practitioners, general practice, allied health clinicians that can also support that person. But again, as Toby has alluded to and others here, is that you need to have a good understanding so that you can work with that patient to give them the explanations and the validation of their condition, because as I said, if they're not understanding why this is happening and why this is ongoing, then they're not going to necessarily improve. So access is around rurality. Like people in rural and remote communities have less access to health professionals in general. So with chronic pain, they'll probably have less access to those that have a better understanding and that can support them, and aren't going to offer them low value care and send them for more investigations or, other things, which is just not going to be, helpful for that person, and it could actually cause further harm for them. And it's also the affordability around access. They're the key barriers that I currently see at the moment. But as I said, you can have a fantastic GP, but if he's looking at all aspects, that's what we're referring to in that, multidisciplinary holistic care, they're looking at, how you're thinking about pain, your function, what are you, eating, and, are you connected with family, or are you disconnected socially, economically, all those social issues. They're all issues that need to be addressed to support that patient to self-manage their pain. And as I said, then it becomes very high value care. So, so they're probably the key issues I would probably highlight. So it exists everywhere, as I said, in a tertiary centre or in community. So it's just a matter of pulling a team together and working with them in partnership and, as best that you can with the resources around you.
And it's certainly one of the key advocacy points for Chronic Pain Australia and others in the pain sector, that we really want to see more community-based primary care, multidisciplinary teams that are fully accessible and affordable for people with chronic pain. Because we see this as, why wait for a tertiary institution when this could be really managed in a primary care setting? And it's a bottleneck a lot of the time trying to get to the tertiary institutions. They should be seeing, the category 1s and 2s that are more complex, whereas the primary care can really help facilitate those patients and see them early, reduce the buildup of chronicity in that space too. So,
yeah. I think you just hit a key there. I don't think what we do well in Australia and probably internationally is prevention. So if we get in early and early risk identification, so this is where the importance of, understanding all of the science behind chronic pain management, and it is really that you can stop potentially that chronicity from actually occurring, so that, all that unnecessary suffering. So again, I think that highlighting that aspect as well. And this is where consumers ask those questions, like if you're not happy with one individual, and, I know it is hard to find access to health professionals and GPs, and there's also costs involved. But I think if you're feeling that it's not right in your gut and you're not happy in that relationship, then hopefully that you can, try and move forward and try and, search for someone that has that you do feel comfortable with to have those conversations.
So we've got 15 minutes to unpack surgery a little bit more. And Dilip, for some people with chronic pain, surgery may be an appropriate option, or it may be, a pain changer for them in that it's really shifted their outcomes, their ability to function, do the things that they love doing. So what's your recommendations to consumers around signs, symptoms that they should look for, of reasonings that could indicate surgical intervention?
Yes. Thanks, Nick. The first thing is, surgery is, in some circumstances, a fantastic treatment for pain. And I'll give you the example of total hip replacement. Total hip replacement is one of the most amazing surgical procedures that's ever been devised. And if we look at people with severe pain from arthritis of the hip, the international figures show that in the hands of a skilled orthopedic surgeon, 19 out of 20 people undergoing total hip replacement will have a good result. It actually improves their capacity to participate in work and other types of activity, as well as it gets rid of the pain, which is what everybody wants. We start moving to other procedures and we see something a bit different. So total knee replacement is another good operation, but we don't get 19 out of 20 good results with total knee replacements. With total knee replacements, we probably get more like about 16 out of 20. And there are a number of people who undergo total knee replacement who will actually end up with very persistent pain after the knee replacement. It's still a minority, so it's still a good operation. When we look at surgery for spinal pain, we start to see some rather different signals. Now, if we're actually doing surgery for sciatica, the much depends on the initial presentation. If the presentation is predominantly pain without significant neurological signs, and those would be things like muscle weakness, difficulty in walking, with severe neurological signs, it may even be difficulty in passing urine, having the bowels open, these types of things. So if we have those serious complications, then surgery is actually quite important in those situations. But, and there's a big but, surgery often does not get rid of the pain. It can improve the neurological function, but it may well not improve the pain. And a general figure for even relatively simple surgery on the spine for a problem with sciatica, we may actually improve the neurological function, but we end up with an increase in the prevalence of back pain afterwards. So about 1 in 6 people who have a discectomy for sciatica will end up with worse back pain afterwards. When we get into the realms of more advanced surgery, that becomes very difficult. And in particular, there's been controversy over the years with respect to the use of fusion surgery in spinal pain. And the figures internationally have always tended to suggest that we're moving back towards what appears to be a recurring problem with spinal fusion for back pain. And that is that many patients will end up with at least no improvement. Some patients are worse afterwards. I say there's controversy there because there are different opinions amongst different groups of surgeons. But for example, 2 very highly regarded surgeons in Australia, both of whom are fellows of the Faculty of Pain Medicine, Professor Lee Atkinson and Associate Professor Andrew Zachest. They published a paper in the Medical Journal of Australia a few years ago, pointing out that unfortunately outcomes for spinal fusion surgery for back pain have always been less than optimal. And despite the advent of many new technologies, there didn't appear to be a great improvement overall. So if I'm actually sitting down with a patient and they're saying to me, Dr. X has offered me a spinal fusion for my back pain, what do you think? I have to just come back to something that puts it on a personal level and say, well, if it was me. And now, of course, the dropping back onto the if it was me arena or area, I'm not the person sitting in the chair opposite me. And we have to try and understand each other. And then there'll always be a bit of a gap there. But for many people, I think that for advanced surgery for pain, really wherever it is, the first thing to say is, what else have we explored? And the second thing to say is, what would you do if things were worse than they are now? And that's a really tough conversation to have with somebody, because you don't want to frighten people. But by the same token, it is important. It's very important for patients to understand that they've been fully informed about where things are. And look, I've had patients who have gone off. Some of them have had spinal fusion surgery. They've come back. They've had a great result, and they've been very optimistic about it. They thanked me for my interest, but told me that I don't need to see them again, which is, I'm happy for them. Conversely, though, I've had patients who've come back who have said, perhaps you were right, Dr. Kapoor, and in that set of circumstances, the last thing for me to do is to abandon that patient. I mean, it's a terrible thing to say to somebody, I told you so, and I would never do that. But again, I think it's a very, very difficult area, because when people are in pain all the time, they want relief. They'll do almost anything to get out of it. The best we can do is to explain in the clearest terms possible what the evidence is.
Wonderful. Toby and Tim, you're both experienced in also assessing patients if they've been recommended surgical intervention. I was hoping, Toby, you could start off by sharing what that's like from your side of things, and where you're seeing red flags maybe, or where you believe it is appropriate and you agree with the assessment.
Yeah, thanks, Nick. And like it is a very tricky thing. As Dilip said, you're being offered something which is promises so much often, and it's hard. I think, and there's a number of things to this, from sort of appropriate social support, and by that I mean not just somebody who's around to pick you up from the hospital and manage you in the sort of post-operative period, but actually having people, family, friends, supporters who understand your pain problems and are on the journey with you, and who are aligned in your thinking about this. That's sort of emphasized element of managing persistent pain, but for another time, I think. But that's sort of the element of which your network is brought into the experience that you're going through day to day, and supportive of that is really critical. But just to come back to what Dilip was saying, I think one of the problems again that we have is that we sort of split off sort of biomedical things from psychosocial things, and thinking about surgery and medication and as part of a series of options that people have to consider and how they manage their pain day to day. And the idea that if surgery is being contemplated, I think it's really important that that's the consumer is given to understand that's one tool in a toolbox, which may or may not do things for you, but it's not ever really likely to be the only tool in your box. And putting all your hopes and all your expectations and all your onto that one opportunity is overloading what surgery can do, because it's it's pretty wonderful, but it's no miracle. And I think for me, seeing folks who have been recommended surgery, they've got a good understanding of what's involved, they've talked to more than one person about it, they have good people around them who are also supportive of the choices they make, but they're also, it sounds strange to say, fairly modest expectations often. They wouldn't be going further if they hadn't zero interest in it, but modest expectations for that particular opportunity, because they know there's a range of other things they're going to need to keep working on. And in all probability, as Dilip said, there may be still some pain afterwards. Even with successful operation, there may still be some pain to manage. And this is not the only thing they're going to need to have a look at. I think that sort of, at least from a psychological point of view, having the opportunity to make choices for yourself and not desperate choices out of, this is my one opportunity, but there's actually lots of things available to me, and this is one of them. And I see it as a decision that I make knowingly as part of a range of things I'm going to need to do to make sure my quality of life stays the best it can be. Because that's, I think we've mentioned this term self-management quite a lot, and the idea that all of us are the masters of our own destiny, and often that gets lost in a healthcare system where you've got people doing things to you, and trying to keep hold of the fact that you can make choices about this stuff. You make choices every day about what you choose and choose not to do. And this needs to be just another one of those choices which is well-informed and well-supported, but not the sort of the golden ticket to something else. One of the questions, just to finish, is asking, Fiona's mentioned about goals, which is again so important here, and what do you want to be different as a result of something? It's got to be more than just having less pain. If people's only outcome is to have less pain, that worries me. But if having a change in what they do, what they don't do, and broadening their horizons in terms of social engagement, work engagement, friends, and so on, if it's part of that, then that's a different story. But if it's just about having less pain, that's a brittle basis to go forward with something that you can't reverse. Sorry, Tim.
Great, Toby. Toby's really addressed that where does surgery fit in the big picture? My comment to people around it is Dilip's given some really good statistics that there are some things where surgery is likely to give a good outcome. But even things that are very good, like hip replacements and knee replacements, aren't bad for the right patient. There's very good evidence that good quality physical interventions beforehand mean a lot of patients. There was a great study a few years ago that when people were given good quality physiotherapy and exercise and they understood the arthritic patterns, then something like 15 to 20% of people voluntarily said, I don't want that joint replacement anymore. So getting good quality physio assessments, understanding, for us to understand what people understand and address those things is very important. So good physical interventions beforehand, before you're considering your surgery. The other question I sometimes ask myself, as well as my patients, why is surgery the last resort? I often say to patients, surgery is either right or it's not right. And so if it wasn't right to begin with, I'm not quite sure why it was right later on. Now, I'm sure don't take that as 100% gospel truth, but you get my point. Sometimes there is that sense of desperation that nothing else has worked, so I may as well do it, as if there are only two outcomes, which is it'll work or it won't work, and we do forget that it can make us worse. And so those are the things I'd suggest is if you're thinking about surgery, know what you should be doing beforehand, because it can be a big step to go towards surgery. And then the other thing, as Toby said, is if you do proceed to spinal cord stimulation or to spinal surgery, for which there are indicators, as Dilip said, then you make sure that you have appropriate physical and psychological support afterwards, so that, as Toby said, you make your improvement after surgery about the whole of life. And when that happens, then you tend to find that people's experience of their pain actually reduces.
That's a really important point, Tim, that I was going to ask Fiona about post-surgical. I've had the surgery. What are my expectations? I think sometimes maybe we might forget all of the other things that need to come into that rehabilitation and working on continuing that biopsychosocial approach.
Yeah, no, I agree. And Tim and Toby, with everything that they've said, and they've basically stolen my thunder here, but I do think a really good assessment and discussion with a patient, so that as they're made aware of all of the implications, what to expect, the possible complications. As I said, that just because the surgery has started doesn't mean that they don't have to continue with their recovery, as Tim said. I absolutely 100% agree with, if you can get pre-assessment and get physical therapy, or if you're on high dose opioids and you want, you can reduce down that your opioids, so and other aspects of pain management, which is around if you're overweight and you're going to have some sort of joint surgery, it's really helpful to look at some dietary aspects, because all of this is going to add value post-operatively, so there's likely to have less complications and you're likely to recover better. So I do think having all of that, being well informed and being aware of all of the risks and the opportunities that you have for further recovery is quintessential, really. And we should do that with any surgery, really, not just, related to chronic pain, but I think any surgery we go into, be well informed. And I don't always mean look up Dr. Google, because sometimes that can bring in more other things. But with the surgeon and the team that you're working with, if you can go in there and try and ask all of those questions that, that you're just uncertain about, and I know that can be quite daunting for patients because they can feel quite intimidated about that. But I think if you, can look up, put a few dot points down, write it down on paper and go in and have that chat with them, I'm sure they'll be happy to answer those questions for you. And that will, allow you to have, a good feeling good going into that surgery and looking at, the opportunities for recovery.
Thanks so much, Fiona. And it's been a massive conversation with the panel today, and hopefully really unpacked some key insights. Chronic pain is complex. It's not a simple black and white process or treatment and management. And I'd like to just pass to each panelist to give final thoughts and tips to the wonderful people who might be out there living with chronic pain. So, Dilip?
Thanks, Nick. Perhaps to come back to something that I think everybody has raised today and that we all understand, but too often too many people forget, is that the person at the heart of this is the patient. and it's a patient who is suffering. And I think if we can begin to understand what is happening with that person and share our understanding with them, even though that may sometimes involve messages that are uncomfortable for people, I think it can perhaps steer us away from other pathways that can perhaps seem superficially more logical, but which at the end of the day may end up harming people. And that's really where we need to concentrate our effort.
And to Toby.
Good question, Nick. I'm thinking at this point, if somebody has watched through to this point in this video, they've got some pretty good ideas in front of them now about chronic pain and its management. So I would be encouraging folks that if any of this doesn't resonate with the people who are working with you, the clinical people, then empower yourself to go back and bring that with them. I think Fiona's point about asking questions of your healthcare providers is really important. You're the boss of you, and you are the boss of this interaction. These people are providing you with a service of one kind or another, whether it's a surgical service or a meditation service or whatever it is. So I would think, yes, if you're at this point in procedure, you listen to this and things you're thinking, well, that's not what they're saying to me, or that's not the message that I'm getting, or I haven't heard that, I would really encourage you to write that down and take it in with you to your next appointment. And if they're not happy to address those questions for you when they can't, then they're not the right person to work with you. And there are plenty of others out there. So power to the people, Nick, is what I guess I'm saying, and to take back that ownership of managing your health.
And
Yeah, I'll follow on because I've got something to say very much associated with what Toby said. Quite acceptably, not all health practitioners understand or really are experts in chronic pain and pain management. And that's okay. As Toby said, go and have that discussion with them. And they may well say, actually, this isn't my area of specialty. Increasingly now, there are people who have this as an area of expertise. As Toby will tell you, not all clinical psychologists do pain management, and that's fine. And so if you need some assistance in that, find somebody who does. There are more and more physiotherapists who have expertise. The Australian Physio Association website can help you find a titled or specialist pain physiotherapist. Some GPs are excellent with their pain management, and others know that it's a limitation of theirs. Back 20 or 30 years ago, the only place you found pain management was in a tertiary hospital clinic. Now there's more pain management in primary care. There are more and more private pain clinics. But my other comment is, I'm quite strong about this. You need a pain clinic that has a truly integrated team. As Fiona said, they need to communicate together, and it's from that integration of care, the true discussion about patients. And so if you're going to a pain clinic, you want a pain clinic where there are multiple people involved and that they talk to each other.
Well, Fiona, last words.
I'll target mine then, because I would have said about the empowerment and validation and listening and support people around you and all of that. So I'm going to talk to the health professional who's listening here and just say, just remember those, the languages that we use. And what Toby was talking about, and Tim, that it can be quite confronting and almost, damaging for some vulnerable individuals, and a lot of people with chronic pain have a lot of vulnerabilities. So think about that, and just have that understanding and just listen, because I know these patients sometimes they're in quick consultations and they feel very dismissed and very much just really want to talk about their story. And I know that's difficult in our busy clinical environment, but and just validating them as well, and working with them around, their patient-centered goals as much as possible. So that's really all from me.
Thank you. Wonderful final thoughts from our amazing panelists. My deepest thanks to Dr. Dilip Kapur, Professor Toby Newton-John, Fiona Hodson, and Dr. Tim Austin. And thank you all for watching this really special segment that I hope has given some validation to your chronic pain experience, some deeper understandings on chronic pain and surgery and helped you through your chronic pain journey. So thank you.